Hey guys, so we're gonna just have a quick little chat on the GI system. So our GI system includes our mouth all the way down into like our anus and our rectum, our teeth, tongue, esophagus, stomach, liver, pancreas, gallbladder, large intestine, as well as the small intestine. So oral trauma is trauma to like our oral cavity. So we can see this in like their face. It's going to affect the bones of the mandible, maxilla, and our like nasal cavity, teeth, and soft tissue, so the soft palate, tongue, their oral pharynx, so the back of their throat. Management is jaw stability. So a lot of the times these patients will kind of have their jaw wired shut. Okay, and those wires are going to help hold those bones in place as they heal. We worry because these patients are at a very high risk of asphyxiation because they can't open their mouth and open that airway. So we need to make sure that we always have wire cutters in the room as well as suction available. So every patient with some sort of face trauma who has their jaw wired will have these cutters. And if they were to vomit or aspirate, and be able to cut those wires and suction whatever we needed to out. Any oral trauma that comes into, we also don't want to place any NG tubes, especially if we have that maxilla and that nasal cavity injury. We don't want to accidentally put that NG tube in through those broken bones and into our patient's brain. Not great. So that's something we would have to do, like an OG tube, or look at like some sort of surgical intervention for feeding. A lot of times when their jaw is wired shut, they are able to like swallow soft foods or like pureed food simply on a pureed diet until we can get those wires out of there. Peptic ulcer disease. So peptic ulcer disease is a break in the mucosal lining. We have some sort of ulcer in the mucosal lining of our esophagus, stomach, small intestine, or even our large intestine. One of the big causes is H. pylori. So H. pylori is a bacteria that normally lives in our gut flora, but when we have high acidic states, when our stomach acid's more acidic, we have more of it, then H. pylori can become kind of an opportunistic bacteria, and it embeds itself into the lining of the mucosa and causes these ulcers. We can also see this from aspirin and other NSAIDs, such as ibuprofen. The antihistamine just kind of breaks down our normal mucosal lining, allowing that acid to kind of wear away and erode our mucosa. Stress, and then smoking. So we can have duodenal ulcers. So these are going to be obviously ulcers on like our duodenum, so in our upper small intestine, and gastric ulcers, which are going to be within our stomach. Manifestations for these patients, so they're going to have burning or pain in the epigastric area, so usually like right above their stomach, right below their sternum. This pain is worse with eating sometimes, worse when they lay down. Complications, what we worry about peptic ulcer disease is GI bleeding and perforation. So perforation is when it's going to erode itself all the way through that mucosal lining, and now we have gastric contents, including gastric acid, spilling out into our peritoneum, or if we're above the diaphragm, right into like our pleural cavity where our lungs and our heart sit. So perforation requires emergent surgery. If we have a perforation or even like a deep penetration, they can go in and place a patch. So it's just going to be an ulcer patch. These patients are NPO for a significant amount of time, like a week or two, so they usually require like PPN or TPN, some sort of artificial nutrition, which we'll talk about. They can also cause obstruction, right, because we can have inflammation and swelling around the area of the ulcer, and then bleeding, of course. So, nursing implications, right? We want to assess our emesis in stool. We want to assess for bleeding, right? Do they have hematemesis? Do they have those coffee ground emesis? Do they have red frank blood in their stool, or do they have melena? So is it like a dark tardy stool? Soft food, when they're able to eat, it's generally going to be NPO for a little while, so we can allow for that ulcer to heal. Again, they might need parental nutrition depending on how long they are NPO. So parental nutrition is when we give nutrients via IV, where enteral nutrition is nutrition through like an NG or an OG or a PEG tube. And again, watch these patients for signs and symptoms of bleeding or that perforation, which perforation we're going to see increased abdominal pain, intense abdominal pain, and maybe signs of peritonitis, so a rigid abdomen, fever, flu-like symptoms. Treatments are going to be a protonic, so a PPI, proton pump inhibitor, to decrease that gastric acid and make it so the environment doesn't really allow for that H. pylori to live, while also protecting our mucosal lining. Octreotide is a medication that we can use in patients when they have bleeding. It's a vasoconstrictor specific to our GI tract to kind of tamponade off any vessels that are bleeding. Bowel rest, so this is going to be our NPO patients, right? Parental nutrition. Nothing to eat or drink. We might put in an NG tube to help decompress that stomach and suction out any extra stomach contents, and then an EGD, so an esophageal gastric study to go in, see if we can find the ulcer. Sometimes they can repair them, other times it's just diagnostic. We can see if it's from H. pylori or if there's another causative agent. Esophageal trauma. So esophageal trauma, we see a lot of this Mallory-Weiss syndrome, which is a rupture of the esophagus. Generally from our portal hypertension patients or patients with esophageal varices. When those rupture, are patients who have chronic gastric reflux, so chronic GERD, and that kind of wears away at the esophagus just above the esophageal sphincter there. This can also be from ingestions of toxins, foreign body ingestion, so we always want to ask patients, especially like parents, what container did they find next to the person? What did they ingest? Some toxins we can have them vomit up. Others we want to give like activated charcoal, insert an NG, and section it out, because we can have corrosion on ingestion as well as when they're vomiting. Foreign body is what we want to know what is in there so we can plan how we're going to get it out. We worry about esophageal perforation, which is life-threatening, as well as, bleeding, and then whatever these toxins or foreign bodies can do to our body, so such as like batteries, bleach, laundry detergent, anything like that, and what it's going to do chemically as it moves its way down the GI tract. So again, treatment, hemostasis, especially for those Mallory-Weiss tears. These Mallory-Weiss tears, they bleed a lot. So we can place a Blakemore tube. So Blakemore tube is just a big balloon that goes down. You can either go down the nose or the mouth, usually the mouth. And it has a balloon down here at the bottom where the esophagus is, as well as a gastric balloon. And we just fill it full of air using like a blood pressure cuff. Until it can tamponade off. These can only be in for about 24 hours, so once it's in, we need to have some sort of surgical intervention planned to go in there and fix these bleedings. Blood products, right? If they're bleeding, we should replace it with blood. So generally, we're going to do our plasma platelets first, and then our packed cells. Maintain hemodynamics with fluids or vasopressors, and then again, that octreotide can kind of tamponade down these blood vessels in the esophagus. Other treatments for toxin ingestion, again, is just going to be like a reversal or activated charcoal or something else to get those toxins out of there. So a bowel obstruction. So bowel obstructions can be caused by herniation, adhesions, tumors, constipation, peptic ulcer disease. Right, these patients are going to have generally some vomiting, some nausea, because there's an obstruction, so food cannot get beyond that point. Tenderness with palpitations, pain in general, and then a liquid stool. It's liquid because only liquids can get around the obstruction, though they don't really have a formed stool. A small bowel obstruction is in the small bowel. This is going to be in our small intestine. Usually they have this intermittent abdominal pain, and when they vomit, their belly feels better. And their vomit's going to be like large, copious amounts, very bilious. A lot of times it could also be like what they just ate, right? Because food isn't getting through. A large bowel obstruction is going to be in our large intestine. Alright, it's going to have kind of a consistent abdominal pain. These are the ones that we really see a lot of that liquid stool. And then diffuse tenderness with palpitations. When we push on their stomach, their whole abdomen hurts, and it's a little less specific location. So nursing implications, bowel rest, again, NPO, nothing to eat or drink. Place an NG tube with intermittent suction, again, to help decrease the amount of stuff that's in their stomach, so we can encourage more of that bowel rest. Pain management, emesis control. Fluid replacements just via IV, so parenteral fluid, and then preparing them for surgery if necessary. Sometimes if it's not a total obstruction, bowel rest and a lot of activity can help prevent surgery and kind of allow things to start moving on their own, right? Because when our patients are up and walking around and moving, we increase our gastric motility and we can kind of get rid of that bowel obstruction. Other times they do need surgery where they just go in, take out whatever's in there, anastomose them, stitch them back up, and away they go. So GI bleeding. So GI bleeding is, again, we're going to have patients who are with peptic ulcer disease, gastritis, esophageal varices, as well as trauma in some of our tumors, so some of our colon cancer patients. An upper GI bleed is more common than our lower GI bleed. And in upper GI bleed, we'll see hematoemesis. So we can either see coffee ground emesis or frank blood in their emesis. Frank blood is going to be a fresher bleed, where sometimes coffee ground it's been bleeding and it's been sitting in the stomach, and that's why it's dark. And then we'll see black tarry stools, right? Because it's going to indicate an upper GI bleed because that blood has had time to kind of coagulate as it's gone through the GI tract. Where in a lower GI bleed, we might see more of red stools because it doesn't have time to coagulate and turn that dark color by the time it's excreted in the stool. Or melena is another name for that. So again, signs and symptoms, melena, hematemesis, we're going to see signs of hypovolemia, right? So tachycardia, they might be hypotensive, anemic, so low H&H. They'll have abdominal pain. And then a positive fecal occult. So fecal occult just tests for blood in the stool. It could be from hemorrhoids, it could be from an upper GI bleed. It's not very specific, but it lets us know that there's some bleeding in there somewhere. Management, scope them, see where the bleeding is. Sometimes they can go in and they can clip where the bleed is. And that clipping is just going to kind of tourniquet it off so it stops. These patients again need to be NPO because we don't want to make any of that bleeding worse. Fluid resuscitation if they are hypovolemic, so blood transfusion as well as like our isotonic solutions. Proton pump inhibitors, they're going to be on protonics, going to be on octreotide, and then antibiotics, especially if they're positive for H. pylori. They need a PPI and then 2 antibiotics to treat that. So let's talk real quick on nutrition. So enteral nutrition is going to be through some sort of tube into the GI tract. So either into our stomach through like an NG or an OG, nasogastric, right? Gastric, it ends in the stomach, or our jejunum, which is going to be like our small intestine. So those are like our J tubes you'll hear. So we have PEG tubes, which end in the gastric, and then a peripheral enteric jejunal tube. Enteral jejunum. We as these in patients who have swallowing impairment, so they might have just had a stroke, they might have had some sort of brain trauma, Parkinson's disease, a decreased level of consciousness, are not able to protect that airway when they swallow, if they're ventilated, or if there's some sort of upper GI obstruction. either like in the esophagus, in their mouth. An NG tube is going to be heard for just for a short period of time. Anything longer than about a month is when we need to do that PEG or page tube insertion. As nurses, we want to assess the tube type, right? Where is it ending? Is it ending in the gastric? So is it ending in the stomach? Or is it ending in the jejunum? Before we ever use any of these tubes, we want to confirm placement with X-ray. Okay, placement confirmation with like the air test is not enough. It has to be confirmed by X-ray before we can use it. And then we want to know what we're feeding them, right? The formula type, how many calories is in it? What kind of nutrition are they getting? Is it high protein? Is it low protein? How much are we giving it to them, and frequency? Are we doing bolus feeds? Are we doing continuous feeds? And then water boluses, which are really important. We can make our patients hypernatremic by not giving the correct water amount, or we can even make them hyponatremic if we're giving too much water. And then parental nutrition is going to be IV. So we have partial parental nutrition as well as total parental nutrition. So this is indicated if our patients are unable to take nutrition in the oral or enteral route. Parental nutrition is really high risk, right? High risk of infection, hepatic impairment, as well as altered nutrition status. So it can make them so they're not able to absorb nutrients once they're done with these therapies through like their normal GI system. So it's kind of a last resort is parental nutrition. Patients who have some sort of inability to absorb nutrients, right? Some sort of absorption insufficiency. They might have Crohn's, short bowel syndrome. They've had a major gastric surgery. So, for example, like those gastric patches, where we're not able to give them anything enterally, we'll have to do parental nutrition. Sometimes cancer patients, if they have malabsorption because of where they're having radiation. Total parental nutrition requires a central line, where partial can be given through a peripheral, again preferably central line, but it's okay peripherally. TPN has to be a central line. Usually we give it at night, and then it's going to require a filtered IV tubing. So partial parental nutrition is going to be our short term, usually for 2 weeks. Okay, again, somebody has a Crohn's flare-up. They're having symptoms of like short bowel syndrome, which we see a lot in like our gastric surgery patients. Partial parental nutrition can sometimes just be vitamins, it can be fluids, it can be minerals, and it can be like our lipids and our fats. It's not always all of them, where total parental nutrition is all of our major and micronutrients. So they're going to be getting their lipids, their electrolytes, their vitamins, their trace minerals, everything that they need is going to be going parentally. It can be used for prolonged periods of time. So here's an example of the tubing setup. So we'll have our parental nutrition and then our lipid emulsion. So our lipid emulsion is going to have like all of our fats and lipids. This will have all of our electrolytes and our vitamins. They go through separate pumps, and then they'll connect over the filter. And they need this filter especially for the lipids. We have to filter out our lipids. And then this picture is kind of hard to see, but you can see that we have all of our measurements of what's in here. It'll tell us the amount of potassium, sodium, chloride, vitamin B, vitamin C, all of that is in there, as well as how many carbs, fats, proteins, lipids that we're giving our patients as well. Okay, that's everything. Thanks, guys.